Okay, you can see my screen, right?
Yep.
We're gonna just start from. Do you guys get like this kind of lab manual? Do you have this?
No, we don't. Other than the one you may have in your notes.
Do you have like? Do you get like something that looks somewhat like this?
No. It varies. We do this one called Pills and McGraw-Hill.
Okay. Are you able to pull one of those up and share it with me so that I can see it?
Yep, let me pull up my screen. Give me a second.
Let me know when you have it pulled up, and I'll stop sharing mine so you can share yours.
Give me 1 second to back out. I'll go to the most current one for McGraw.
In case anyone's wondering, it's root beer. It's IBC root beer.
We're all good with it. I'm not arguing.
I just need my sugar intake for today.
And I also need my food as soon as it gets here, but it's not going to be here for like another 10 minutes. If anybody's curious, yes, it's tacos.
I still want to try the, I know it's not going to be good, but I want to try the Cheez-It Crunch Wrap.
I actually like the Cheez-It in the Crunch Wrap form better than I do the other way.
I might go get one tonight.
Did we have a lab this week, or for week 6? I think we did. I know for week 5 we did. I'll do week 5's. I hate accessing them once we've gone through them because... Oh, thanks. Electrical access. See your port. Alright. I've got mine up, Drake.
Can you share it?
Yes, I can.
This is week 5?
This is week 5. We got a ton of, what we do is we get a ton of questions like this.
Okay.
Now my internet's going to be crap. I think all hell just broke loose outside. It did.
Raining?
Oh, yeah.
Nice.
It's literally
all it is. It's just you get.
No, then we have lab. Then we have actual lab. We do. But like this was on the test.
The questions first.
You get questions, images. Like I missed that one. I did not care. And we get full credit for it regardless of if we get it right or wrong.
Okay, what does the lab actually look like? Do you have to click all the way through this to be able to see the lab?
I think it's 25. Hold on. It's 21 and 22. Right here, electrical access. And this is what our lab looks like. Next. Skip quiz, because I'm not doing the pre-quiz again.
Okay. Okay, yeah, this is super similar to essentially what you would do in actual lab, just you have to do it virtually.
Okay.
So I'm going to use the lab manuals.
That's fine, because that's what I've been studying regardless, and I think Kat has too.
Okay.
Yeah, I have the manual too.
Yeah. If you want to stop sharing your screen, and I'll restore mine.
I'm going to hop out and close all my extra windows so my internet works.
Hi, Liz. Okay. Liz, with this having the lecture exam tomorrow, we're gonna fly through a chunk of this, and when we get towards the end of the lab stuff, it's gonna hit heavy into exam 2 heart stuff, because it's gonna get into the EKG, heart sounds, all that kind of stuff. Sound good? Can everybody hear me?
Yes, sounds
Yep.
good to me.
Okay. So strategy for prepping specifically for the lab exam. I would use the lab manual if you have my notes, you should have the lab manual. Go week by week, and honestly, the first thing that I would do is straight up start by reading it. Like, read the whole lab manual, read through it. Anything that, like, words and stuff that you don't understand, highlight and make sure that you know the definitions. So immediately starting off, muscle contractions, isometric or isotonic, knowing the difference between that. So isotonic, meaning that it has the same tension remains constant. The muscle's maximal force of contraction exceeds the total load on the muscle. Isotonic. So that means the muscle size isn't moving at all. So like pushing the wall, for example, if you lean against the wall and you push as hard as you can, your muscles aren't actually changing length, but you're increasing and giving maximal force. Sorry, that's isometric, what I just described. Isometric is when the length of the muscle remains the same. Sorry. There. Isotonic is the tension. This can only occur when a muscle's maximal force of contraction exceeds the total load on the muscle. So we're applying the same maximum amount of force, and we're applying the exact same amount of force the entire time they're going. So there's no move. There is movement. There is a change in muscle length, but not change in the overall tension. Isometric, most example they're going to give you is like a plank. Isometric, length of the muscle stays the same. Voluntary muscle contractions can be classified several different ways. We have eccentric or concentric contraction. Easiest way to describe these two, eccentric means the muscle is active but lengthening. Concentric, the muscle is active and shortening. That's really all you need to know about those two. You can take it more like next step, like the way he might ask the question, the fancy terminology. The force generated is sufficient to overcome the resistance. That just means you're putting in more force than what's required to move something. And same with eccentric, the force generated is insufficient to overcome the resistance. So like when you're doing dumbbell curls or something like that, you curl the dumbbell up, up, up. And then when you're bringing the dumbbell down and you control it on the way down, that's eccentric contraction. You're controlling it down, but you're letting the dumbbell and the gravity win versus, so then the muscle is lengthening. I don't think they usually ask this, but muscle strength is built during eccentric contraction. So building muscle, building strength is done by the actual eccentric force. Muscle coactivation is a phenomenon in which a muscle is activated coordinately with another muscle. It is the simultaneous activation of agonist and antagonist muscles. We need to know what those words means. Agonist versus antagonist. Agonist is the main muscle activating, so bicep curls, biceps. The antagonist is the opposite muscle, so that'd be the triceps. Although both of them, when we do any kind of movement, so if we're curling up like this, our bicep is the one that's more active, but our tricep is also going to activate a little bit to help stabilize the whole joint, stabilize the area. to allow us to do that movement. That's called that agonist-antagonist muscle coactivation. There's our definitions: isometric, isotonic, concentric, eccentric. This just goes over how to perform the experiment. This is going to show us this. You're probably going to have a picture just like this, or something similar to exactly like this, when you have your test. Okay, this exact kind of picture, and it's gonna be like at which chunk. We're gonna have like 4 pictures just like this, and it's gonna say which of these is the agonist muscle during this movement, during tricep extension, or during bicep flexion, or elbow flexion, or elbow extension. So during flexion, the bicep is the agonist. So right here we can see this first chunk. That is going to be flexion. The antagonist is activated, but much less. Which muscle act the agonist during extension? So here, this is going to be our extension. So this is what flexion looks like with at the bicep and at the tricep. And this is what extension looks like at the triceps versus the biceps. We also look at, concentric versus eccentric contractions. Whichever muscle is shortening, that's the one that's going to be the most activated. So in this case, there's our concentric isotonic contraction of the biceps, eccentric isotonic of the biceps, concentric isotonic of the triceps is the big one, and then eccentric isotonic contraction of the triceps is the small one. Great electrical activity noted with concentric activation. Basically, each of these questions down here are most likely what's essentially going to be the questions on. Most of your questions are going to come directly from these kind of questions. Abnormal coactivation, if there's any kind of damage to any of the muscular tissue or any of the nerves, that can mess with stuff. This is just more questions kind of about the experiment in general. Isotonic and isometric contraction based on the tension, like what's changing, just beating into isotonic versus isometric, which we already talked about. More definition stuff: afferent neuron, efferent neuron, the effector, the receptor, because all of this down here, this is our knee-jerk reflex. You have this whole thing. So in test 1, when you had questions about the knee-jerk reflex, do you guys have a fair bit of questions on knee-jerk reflex in test 1?
We had like 2 or 3. At least mine did.
I would expect for you to have at least 2 or 3, if not more, questions, almost the exact same type of questions about knee-jerk reflex on lab exam. So just remember, excuse me. Remember that the stimulus and the response do not count as part of the reflex arc. You have the receptor, the muscle spindle, travels along the afferent neuron, and it bridges across, enters in the dorsal horn, attaches to the somatic motor neuron, which is the efferent one, which goes to the quadriceps, and then you have the what's it called? The something coactivation. My brain is forgetting exactly what it says, what it's supposed to be called. But is it the agonist antagonist coactivation? Is that what it's also called with?
Isn't it like something inhibition, like reciprocal inhibition or something like that?
Yeah, reciprocal. That's what it's called. Reciprocal inhibition. And then you also have the, what do they call them? The cells of like Ranker's cells, or whatever they're called. that their job is to sit at the somatic motor neuron and self-inhibit so that the signal doesn't continuously fire for too much. All of that kind of stuff is going to be on the lab exam as well. You're going to see it all again. Then you also get alpha gamma coactivation, where it comes back, the gamma fibers come back to innervate the muscle cells around the muscle spindle to keep it taut. Hopefully, I'm not going to spend a lot of time like diving into each of these things, because this should be just like, these are the stuff that you should already know. I mean, if you don't, make sure you write it down and come back to this stuff. So the gamma motor neuron, all that kind of stuff. Glutamate versus glycine. Remember, glutamate activates, glycine with the I inhibits. Renshaw cells, that's what they're called. The negative feedback loops in the alpha motor neurons are done by Renshaw cells. There's also GABA. GABA is another inhibitory. All the different steps of the knee jerk. Here's the definitions: alpha gamma coactivation, reciprocal inhibition. This literally just walks you straight through exactly what each of these things do, or like what's exactly happening. This just goes through all the procedure stuff. This is going to show you the actual knee jerk reflex. Can you see it? The reflex arc is the patellar triceps reflex. This is going to come back again from test 1, comes right back. Monosynaptic reflex arc, the difference between monosynaptic versus polysynaptic. Meaning monosynaptic means that there's only one connection point. It asks about the receptor, where each of this stuff is coming through, the neurotransmitter that's released at the neuromuscular junction. All of this stuff, which should be, exam 1 material repeated again. Between strike force and EMG activity, they're directly correlated. Because if we think about the harder that you hit the patellar tendon, the more you're actually the more stretch you're gonna cause, the more quick lengthening you're gonna cause. That increased speed of lengthening and tension is felt by the muscle spindles, and the muscle spindles are gonna respond with a stronger force. That's typically why when doctors go to tap on reflexes, they'll tap light first, and then they'll tap a little harder and tap a little harder until they get the response. Skeletal muscle and motor unit recruitment. Here's more. Remember all of this stuff. FGSO are slow, are type 1 and type 2, type 1, type 2A, and type 2B muscle fibers. The slow twitch oxidative versus fast twitch oxidative glycolytic versus the fast switch glycolytic fibers. Remembering there's a nice little chart in all of the material that shows you all of the properties of these. Honestly, if you remember mostly the function, kind of what their job is, where the slow twitch is for our posture muscles, is for the long endurance muscles, those marathon muscles, versus the fast twitch glycolytic fibers are our sprint muscles, are our super heavy, big force muscles. You can remember kind of what their purpose is and think about your own experience. Like, is it easier to leisurely stand in one place for an hour or power lift 500 pounds for an hour? Like, it's not, you just think what the muscles do, think about the activity, and from there, hopefully, you can sort out kind of what muscles would need more mitochondria, which ones would be fatigue more, which ones are going to fatigue less, that kind of stuff. The order of recruitment as well. that goes through. So he'll give you different examples of you perform this exercise or this thing, or you go to pick this up or do whatever, like how many motor units are activating, that kind of stuff. The definition of what is a motor unit will be a question. It always is. Order of fatigue, kind of what is muscle fatigue. The main cause of muscle fatigue. What is the main cause of muscle fatigue? What causes our muscles to fatigue the most often?
Exhaustion.
Exhaustion from what? What's
Exercise.
causing exhaustion? From exercise. But what actually, think deeper, think more of like the biochemical reason why our muscles fatigue.
No oxygen.
Yeah, either they don't have oxygen. If you don't have oxygen, what energy system are we running on? How are we getting our ATP?
Glycolysis?
Yep, through glycolysis. Glycolysis makes pyruvate. If we don't have oxygen, so if we do have oxygen, that goes and gets turned into acetyl-CoA and goes into the Krebs cycle. But if we don't have oxygen, what does pyruvate get turned into?
I do not remember.
Would that be the anaerobic or lactate?
Lactate, yeah, lactic acid. If we think about biochemistry, acids, what's the definition of an acid? What does an acid do? What does an acid donate?
Electrons or something like that?
Electron, what is it usually, what's attached? What are those electrons attached to?
Mm.
Hydrogen, right?
Oh.
As this is why you get, like, this is going to start where we start to connect the dots of a lot of things. It's like biochemistry 1, it comes back full swing in a lot of these processes. So we need to think back and try and remember those processes, okay? So lactic acid gets formed. When lactic acid is formed, it's an acid. Acids tend to donate hydrogens. When we have an increase in hydrogens, what happens to our pH if we increase hydrogens?
Becomes more acidic.
It gets more acidic. Is that pH is coming up or going down?
pH is going down.
pH comes down, right? I'm saying all of this because this is going to come back. Later on in this class, this comes back. So we need to remember this stuff, okay? So when we get pH, do you remember how we talked about how our pH value within our body needs to remain within a very specific region for everything to work nicely? You guys anybody remember what those values are, where our pH is supposed to stay?
7?
7.65, something like that.
7.35, 7.35 to 7.45 is where everything still works. As soon as we get out of that range, things stop working. So literally, when we talk about muscle exhaustion, we get lactic acid buildup because we're using up all of the oxygen within the muscle. So we release lactic acid. We have a bunch more lactic acid. We have a bunch more hydrogens. We fluctuate the pH, and all of a sudden, a lot of our typical systems that work really, really well usually can start to struggle a little bit. And that's what sort of starts to lead to, that's what leads to muscle exhaustion, is that change in pH, and then things can't quite operate at the same levels continuously as they were. Okay, I went a little bit deeper than we needed to for this test, but this is going to come back really, really heavily, this whole idea of pH and all this stuff, later on in this class. So I think like your guys' next 2 units, within the next like 2 units, 2 weeks or so, you guys will see that all come back with like blood flow and stuff. Okay. That's all of that first lab. So highlights, remember our muscle fibers, all of the attributes of those muscle fibers, know what a motor unit is, know the definition. The reflex arc, remember the knee jerk reflex arc, how involuntary movements are faster than voluntary because they don't have to go all the way up to the brain. Recognize that whole arc, everything that goes on in there, what all those things are called, what the Renshaw cells are, your muscle anatomy, isometric versus isotonic versus concentric versus eccentric, all this stuff, that's all going to be on this test. Week 3 lab. Was this really week 3? Cardiac cycle, is this right, Elizabeth?
Say that again?
Was this right? Was week 3? Did you jump right into cardio? Were you doing heart stuff before? I guess, yeah, that makes sense because like week 4 is heart stuff.
Yeah.
But
we started heart stuff really early.
Yeah. Okay. Sweet. And this starts building immediately into the next chunk of material. So the cardiac cycle, that's the little graph that we were talking about, the cardiac cycle. Talk all about the pressure, pulse pressure, ejection. We'll keep going. Look at the actual the cardiac cycle and heart rate, measuring QRS, measuring R wave to R wave to calculate heart rates, all that kind of stuff. A lot of this lab exam is going to be definitions like systolic blood pressure, diastolic blood pressure. What does that mean? Mean arterial pressure. These equations, diastolic pressure plus 1/3 pulse pressure, those are going to pop up. If you don't have some sort of equation sheet, now's the time to start to make one. I'll actually start one now so we can have it at the end. Mean arterial pressure. This is AKA MAP. Equals diastolic pressure plus 1/3 pulse pressure. Pulse pressure, also known as PP, equals systolic pressure minus diastolic pressure. Okay. All of this, that's kind of just like the lab itself. This guy here, our Wigger diagram. This guy here and our curve. Let me pull up the cardiac, just a cardiac cycle to throw on here. Come on. There it is. That's the one that I want. This cardiac cycle right here. This is our best friend. Right here. Looking at this chart right here, some of the questions that you're going to get. He's going to give you this chart right here. Looks very, very similar to this, except more than likely they're probably going to have numbers here and numbers here and here to measure, you know, the maximum systolic pressure and the diastolic pressure, okay? So what you need to be able to do on this chart is calculate the mean arterial pressure and the pulse pressure. So we take the systolic pressure, so wherever the systolic pressure is, so we look at this portion right here, the pressure on the Wigger diagram, 0, 20, blah, 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 all the way up to here. Bam, level with 120. Systolic pressure is 120. Diastolic pressure, that's not quite right. Where? I just noted that Wigger diagram looks weird. It shouldn't go down to 0.
For that, the one on the left, Drake, he gave us a mock practical just to kind of give an idea of how his questions would be.
Yeah.
He had that on there, and it was LMNOP or LMNO or something like that. And it was like, what was the question, Kat?
He would just ask like, what happens at number L and whatever, or when does the relaxation begin and stuff like that.
Okay. Yeah, we're just knowing this whole part where you have diastolic filling. The first 75% is passive filling. The second part is active filling. The last 25% is active filling. Isovolumetric contraction, knowing when the valves close. So the semilunar valves close up here. The semilunar valves open here. The AV valves, the mitral valves, the AV valves open here. The AV valves close here. So yeah, I would know, you need to know this entire thing super, super well. Like what happens at every single piece of it. Like if you haven't drawn this out, we drew it out last week, I think it was. And yeah, this will be a good chunk of questions. You'll probably have 5 or 6 questions on this stuff. And then from there, like you'll have extra questions that kind of branch off of that. Getting to ECG stuff. So I wouldn't pay too much attention to this chunk right here. I don't love, because electrical signals, so the electrical signals do not tell us when things contract. Okay. A lot of times professors like to mess with these kind of questions. The electrical signal itself measures electricity. It's measuring electricity. So like the EKG is measuring the electricity traveling through the heart. It's not measuring the muscle contraction. We know that in a typical situation, some point after, you know, or like after the beginning of the P wave, somewhere after the beginning of the P wave, the atria are going to contract. At some point after the beginning of the QRS complex, the ventricles are going to start to contract. It isn't always at the top or at the whatever of that specific spot. It's somewhere around there. Okay. I don't think he'll be as mean as Dr. Van Winkle with those questions. But just understand, like, if you get a question where it shows you an EKG, it shows you the electrical activity, and then it asks you, show me, or when exactly, based on the EKG, where exactly does it start? And one of your answer choices is you cannot tell based on the information given. Pick that one, because you can argue it very, very well. If the teacher has an issue with it, you can make the argument very, very well. Like, that's electrical signal. That does not tell us the muscular activity. It completely depends on that specific heart, the specific reaction time, the specific, like, a whole bunch of other factors. You cannot tell when muscle contracts just based off of the electrical signal. Does that make sense?
Yes, thank you.
Okay.
Yes, I like that answer.
Drawing this whole thing. Draw that, draw it, draw it, draw it, draw it, draw it a whole bunch of times. When you look at, this is another graph, taking the components of the cardiac cycle. This is just another way to draw it. Essentially saying the exact same thing. The question that'll really probably trip people up. Did he ever mention this? The inosequoia or dicrotic notch?
I cannot recall hearing that.
So the isovolumetric relaxation, like as soon as it starts, the valve, like, starts with the valve snaps shut and things start relaxing. This little notch right here, this little blip right there, is when you get what's called the dicrotic notch. I'm not sure if he'll ask a question, but usually there's like one question about the dicrotic notch. The event responsible for that is the beginning of the isovolumetric relaxation, the closing of the aortic valve causes that little blip, a little change in pressure. That's all. It's nothing super special. It's just an identifier, like, hey, this is where the valve is closing, and pressure changes because that valve closes. Now, this part isn't fully filled out. Interesting. Okay. This, like you said, these kind of stuff, label the following: diastole, ejection, isovolumetric stuff, all of what's happening in all these different spots. This is all going to be on the test over and over and over and over and over again. These are kind of our normals. Remember, heart rate. What's our normal heart rate? Between what and what?
60 and 100.
Yep. If it's more than 100, what do we call it?
Tachycardia.
If it's less than 100, what do we call it?
Bradycardia.
Bradycardia. Good. You might see these words, so end diastolic volume or end systolic volume. That's telling us between here and here how much blood we're actually coming through. So if our end diastolic volume is 130 milliliters and our end systolic volume is 60 milliliters, that means how much blood did we move from point A to point B?
So what are those? Ventricular and diastolic volume and systolic volume?
Left ventricular, so the left ventricle, and diastolic volume. So the volume, the amount of blood in the left ventricle at the end of diastole. So end of diastole ends right here. So at the end of filling, so after the left ventricle has been completely filled, it has 130 milliliters of blood inside of it. At the end of diastole, at the end of the filling period, it has 130 milliliters of blood.
Mm-hmm. Thank you.
Left ventricular end systolic volume, that is the opposite of that. At the end of systole, so after post-ejection, it ejects, and the aortic valves close, we're left with 60 milliliters of blood. So there's still a little bit of blood left within the ventricle after the heart has beat. So we look here, that's about 70 milliliters of blood actually moved through. So, and we can see that that right there, 136 to 60, that is going to be our output, our cardiac output. So our stroke volume equals end diastolic volume minus end systolic volume, because that is how much blood we pump out of the heart with each contraction. That's our stroke volume per stroke per beat of the heart. So what is the stroke volume? 130 minus 60, 70 milliliters. What is the normal range for stroke volume? I don't remember what the exact normal range is, but that's about normal. Cardiac output, more equations. Cardiac output. This is going to be our stroke volume multiplied by our heart rate. Cardiac output is also labeled as CO. So stroke volume is 70 times heart rate. Heart rate is 80. So 7 times 8 is 70 times 80 is 1,500. 1,500, that's in milliliters. So it's 1.5 liters per minute. Does that make sense how I got there?
Yes, thank you. Just a lot of steps.
Yep, it is a lot of steps. And that's why you'll get like these kind of multi-step problems where it's like, okay, you need to go from this to this to this to this and work your way to get there, okay? And always double check units, because you're going to be changing from milliliters to liters pretty often in the questions. The pulse pressure. So pulse pressure, we already looked at that before. Systolic pressure minus diastolic pressure. So 120 minus 80. That's a difference of 40. So 40 millimeters of mercury right there. The two volumes that make up end diastolic volume, it's that that's a bad question. I don't know exactly what that's saying. That's fine. Ejection fraction. I don't know if he'll ask you guys about the ejection fraction. This wasn't, we're kind of getting to the range of stuff that wasn't talked about as much. Ejection fraction is going to be the stroke volume divided by the end diastolic volume. Because if we look at that, the end diastolic volume is the amount that we started with, and the stroke volume is how much we pushed out. And then because it's a percent, we multiply it by 100 to give us a percent. That's telling us how much of the blood that was originally in the heart actually got pushed out of the heart. Here we go. This is my question that kind of was talking about. You might see end diastolic volume. End diastolic volume. Here's diastole. This whole chunk right here. Bam, 140 milliliters in this graph. Value of the end systolic volume is 50. What is the value of the stroke volume? End diastolic minus end systolic gives us 90. Value of the ejection fraction, we go 90 divided by end diastolic. Do the math real quick. 90 divided by the end diastolic volume, which is 140. times 100 to give us a percent. 64.3%. And then we have separating systole from diastole right there. Sometimes that's a question in and of itself. They ask you, where does systole and diastole, like where does it start? Where does it end? Where would the line be that would separate them? The first heart sound from...
I'm sorry, can I stop you? So
Yeah.
when they ask me where is systole and where is diastole, how do I describe that line? Because it's like going through the middle. I was just going from D to B.
It'll be multiple choice. So you could, yeah, so it'll typically be like the answer will be like D to B. So look here, so D to B counts as here, so D to A to B. That counts as diastole. B to D, so B to C to D, counts as systole.
Made more sense, thank you.
Yeah. Heart sounds. When do we hear heart sounds? What is happening when we hear a heart sound?
The valve is closing.
Exactly, valve is closing. So where these letters, A, B, C, or D, do we hear the first heart sound when the first valves close?
Wasn't it B?
Yeah, it's B, because which valves are closing at B?
A, B?
Yep, our AV valves. So then where do we hear the second heart sound?
C or D?
You tell me. Let's work through it. So here is, right, B right here, the AV valves are closing. That's the end of diastole. Here's the beginning of systole. At the beginning of systole, this part right here, what's this called right here? Going from B to C.
That was the isovolumetric contraction.
The isovolumetric contraction. During that, we're keeping the same volume. We're building pressure, building pressure, building pressure, building pressure, until finally at C, what happens?
Oh, one of them is going to open.
Yeah, which valves open at C?
Was it the AV? Because it closed at B, so it would open at C.
Semilunar.
Yeah, so the semilunar valves, so the AV valves, they closed during, because so the AV valves open during diastole, because during diastole, that is ventricular relaxation, and we fill the ventricles during that time. So the AV valves open down here at A, allow for filling. AV valves close at B. Our ventricle contracts, it increases pressure. The semilunar valves, the aortic and the pulmonary semilunar valves, at C open, blood gets pushed out of the heart until it gets to D, and at D, the semilunar valves, the aortic and the pulmonary semilunar valves, close at D. And as soon as those close, we begin isovolumetric relaxation. Back at A, our AV valves open again, heart fills, they close, ventricle contracts, and it repeats just like that. So at D, we hear the second heart sound. S3 and S4 can be heard between A and B. Did he talk at all? Do you guys remember? Did he talk about at all what S3 and S4 actually are?
I don't think so. I think he just said that C3 can be okay with children, but pathological in adults. And as far as always pathological, that's all I can recall.
Yeah, that's pretty much the most important part. If you need to know if they are pathological, this is the sound of blood leaving the atria and hitting a non-compliant ventricle. That's what both of those sounds are, S3 and S4. Basically, a non-compliant ventricle means that the ventricle is old, or it has like plaque or stuff build up on it, so that it's not as soft and squishy, and it can't, kind of hold and like accept and easily like gently catch the blood as it falls down into it. Instead, it kind of hits the ventricle. It's more like a wall, kind of like think of like a water balloon hitting the ground. It kind of makes a splat sound. Versus like if it lands in sand or like into more water, it just kind of like dissipates into it. So, okay, that's all of that material. Let's check and make sure we have all of our equations. Cardiac output, stroke volume, ejection fraction. Good. Any question about this heart stuff before we keep going?
No, right now, thank you.
We good. Major eye roll. We didn't have that one. We had the one we looked at. I showed you that we went through last week.
Yeah. And a lot of this is just kind of whatever stuff. Sometimes, I'm not sure if he'll ask this question. Sometimes they'll ask you questions about the leads themselves. It's typically like 1 or 2 questions where the question will be like, for lead 1, where are the electrodes placed?
He did
Right.
ask that on our practice.
He did? Okay.
It was lead 3.
Okay. One of the ways that you can remember that is if you think about your mean electrical axis. Right? If we know where our things are, so we have our little circle, right? This is lead 1. This is lead 2. And then, not a super even circle, but whatever. This is lead 3, right? You can look at these if you know this is negative, this is positive, this is negative, this is positive, this is negative, this is positive. You can take each of...
Remember the negative and positive signs, or do we just remember it?
You just kind of have to memorize it.
Okay, sorry.
You draw this enough times that you remember it. You can draw a little stick person. Arms out to the sides, legs here, as if they're facing you. And so we look at this. Okay, lead 1 on the stick person, they're facing us, so this is their right to their left. So we know lead 1 is from the right wrist to the left wrist. Lead 2 right here on the right side, so that's got to be the right wrist to the left ankle. Lead 3 has got to be the left wrist to the left ankle.
One good way, can I chime in with a little mnemonic for remembering how they're placed?
Sure.
If you want to remember, when you put EKG stickers on someone, it's always white over right, smoke over fire. So white is right. Left would be red, lead 2. Fire is lead 3. Or, yeah, smoke over fire. Sorry, I said that backwards.
Okay. I probably won't ever remember that, but
It was a
helps you or
helpful
helps somebody
tip when we
else.
did school for
Perfect.
a paramedic.
Yeah. You'll probably have 1 or 2 questions like that. This is sometimes a question, just generally like, what is it? Einthoven's law. Basically, what it's saying is that lead 1 plus lead 3 equals lead 2. So if you think about like physics and the vector stuff again, if you add the arrows together, lead 1 plus lead 3 works out roughly to the direction of lead 2. So you'll typically have 1 question about that, about Einthoven's law. Just like, hey, what is it? It just means that adding together lead 1 and lead 3 will give you lead 2. So lots of stuff all through here. Did you guys have a bunch of practice questions about left versus right axis deviations?
Not too many, but they were there, yeah.
We did a few, like, in our case studies. It's like, hey, is this right axis, left axis? Yeah. Yep.
There was there was like a worksheet that we had
Yep.
that was just like a bunch of like EKG pathology type questions. Let me see if I can find.
That's where I was talking to Kat earlier about this. When it's right axis deviation, is it typically right heart hypertrophy, or if it's left axis deviation, would it typically be left axis or left heart hypertrophy or left ventricle?
So it's always going to be, actually it's right here, let me. When you have axis deviation, it's always going to be one of these causes. So for example, right axis deviation happens because of right hypertrophy, right bundle branch block, or ventricular injury on the opposite side. So left side injury. If it's a left axis deviation, it's left hypertrophy, left bundle branch block, or injury to the opposite side, so right side injury. These are the only 3 reasons that we talk about axis deviation. So you're going to have 2, so it's same, opposite. So right-sided hypertrophy, right-sided bundle branch block gives us a right axis deviation, and a left-sided injury also gives us a right axis deviation. Left hypertrophy, left bundle branch block, or a right-sided injury, so same, opposite, gives us a left axis deviation. And that again is just kind of, you see it enough that you just learn it. You can work it out in your brain as well, kind of why it does that, but it's easy enough to just sort of remember. Hopefully it is, at least. Okay, week 4. And this basically covers all this stuff. So hypertrophy, the damage, bundle branch block, all that kind of stuff. The whatever causes a right axis deviation gives you the other ones. This is just where like all the different placements, calibrating, recording, looking at the EKG right here. This is also going to be really, really big, you guys. Unfortunately, this is again just raw memorization. Like you have to just memorize this stuff. Okay. the P wave, QRS complex. Specifically, I'm going to give you the ones that you need to know for time-wise. You need to know the P wave. You need to know the QRS complex. You need to know the PR interval. And you need to know the ST segment. I'd say less so the ST segment. You can probably remove that one. These three, though, I'll do this. Most important, PR interval and QRS complex. You absolutely have to know the time ranges on both of those, because changes in time on either of these indicates pathology. And that will hand you the answer to multiple choice questions. Okay. Outside of these two, the next one that's important to remember would be the P wave. Then after that, the ST segment. Okay. See if he talks about it here. ST segment.
The assignment we had last week, Drake, had the whole ST elevation and the.
That's what I was about to talk about. The ST segment. What would cause ST segment shift? Either myocardial ischemia or infarction. Do you guys know what's the difference between ischemia and infarction?
Infarction's the blockage, correct?
Ischemia is so ischemia, and this is always a test question as well. So ischemia equals not enough blood is making it to the tissue, but it's still alive. Infarction equals no blood to tissue equals cells are dead.
It's also a question in EEC.
A question in what?
It's also a question in the EEC, medical terminology stuff.
Okay, and with the ST segment, with ischemia, you'll see depressed ST segment. Correct me if I'm wrong on this, I'm 90% sure. Infarction, you'll see elevated ST segment.
Yes. Depression or inverted T wave is ischemia. ST elevation is injury.
Yeah, the way that you can think about this is if something's not getting enough blood, like if your muscle doesn't get enough blood, gets tired, gets droopy, gets sad, so ST segment gets depressed. And specifically, make sure that you recognize this. An elevation or depression is at least one full small block above or below
baseline.
Yeah, the baseline, or the also known as the isoelectric line, or the J point, I think is what they also call it. It's our ST segment. Yep. There's heart rate stuff, mean electrical axis. How do we feel about mean electrical axis stuff?
I'm okay with it. I feel decent with it, but it never hurts to just hear your take on it one more time with the shading method?
Okay. Kat, did you get to watch the last recording?
Yes, I watched it.
Okay. All this stuff. This is lots of like just like the actual measuring stuff that was with the lab. Don't need to worry about this. That's all.
No branch block.
extras.
Yes, and heart blocks. That's the other thing.
Yeah. Okay. Let's see. Let's just do one. Oh, I'm gonna have to find my pretty cardiac acid axis. Oh, computer. Sorry, I have like 40 windows open right now, and like tabs because I've been working on my thesis paper, so my computer's just struggling with everything that's opened on it right now.
Hey, Kat, did I send you the picture about the heart block song?
No.
Okay, I keep forgetting to send it to you in Messenger.
Okay. Okay. Jeez. EKG. So here's our little circle. Let's split it all up.
Pardon me.
What I'm gonna have you guys do, check this one and do it on your own. I need to go put my baby to bed.
Okay.
I'll be back in about 10-ish minutes, okay?
Okay.
Right back.
Hey, Kat, we did that one earlier. Hey, Kat.
Yep.
That's the same one you and I did earlier.
Yeah, well, I guess it's a review, right?
Yep.
So, yeah, that'll work.
What is it?
What is what?
What's the answer?
Oh, I don't know yet. I'm not ready. I just now came up to my desk.
It's the one I drew out for you earlier.
Oh, okay. I remember now.
They're like, how'd you guys know that? I go, we did it earlier.
Then look at 3, like, okay, there's the isoelectric, and now I just need to
The
know what
isoelectric.
to do it.
Yep. AVR is perpendicular. And yeah. Yay. My dinner was good. Woohoo. Oh, my hips. Did you get the picture I sent you, Kat?
Sorry, what were you saying? I went to grab some water.
Did you get the picture I sent you in Messenger?
I don't have my phone. I'm gonna go grab it.
Okay.
I'm back.
Woohoo!
Did you miss me?
No, we had the answer figured out in like 2 minutes.
Okay, nice.
Only because we had that question earlier today.
Oh, like this exact question?
Yep.
Oh, nice. Well, then I'll do it super, super quick. Lead 1, negative versus positive. We find the perpendicular. It's positive. Can't
It's
be
got
any of this.
isoelectric too.
What's that?
It's got an isoelectric too.
Yep, lead 3, biphasic. Lead 3, positive, negative. Find the point to it, so it's either going this way or this way. Lead 2 is positive. Lead 2 is here, positive. Can't be that negative, so it's essentially going this way. So somewhere between 90 and 30. Parents are probably like 60 something.
So is it the AVR and AVF? Are they both like the positive and negative backwards, or is it just the AVR?
Just AVR, because AVF is positive, negative. AVL is let's see, this is AVR up here, right? And that's positive, negative. And then AVL is this one, right? Let's see. Pull up the actual slide. Or better, let me just pull up the meeting from last week because it should be saved in the chat there. Oh, other teams. See, here we go. AVL positive, AVF positive down here, all the right. Yeah, so essentially everything is positive, kind of down and to the right, except for AVR. AVR is the only one that's negative.
Thank you.
Do you guys want to do more practice with the electrical axis? Looks like you kind of have it down.
I'd go for 1 or 2 more, honestly.
Okie dokie. This is one that you might see, not this probably, you'll probably see almost this exact one, not for like ECG, not for like electrical axis, but for like diagnosis type stuff.
From BFib?
Yeah, I'm pretty sure. Ventricular. Yep. Yeah, ventricular tachycardia. Not fib. VFib is not like if you look up fibrillation. Yeah, it's not as clean as like consistent. It's way more sporadic. And kind of all over the place. It's not as like with this, you can still get some kind of semblance of like waves. When you look at fibrillation and fibrillation and stuff, they're much more random. Let's see if there's an example in all of this. Yeah, ventricular fibrillation. See how all of these, some are higher than others, drops way down. Kind of, it's really random, sporadic. There's no like these ones up here. It's funky, but it's consistent. See how every one looks just this. It looks exactly the same. Yes, no, maybe.
I do. See it.
Okay. So because every single one of these is exactly the same, that's just our ventricular tachycardia. When they start to look funky, so like ignore all this stuff at the beginning. This is something else going on. All of this here on the right side, that is our ventricular fibrillation. There's no pattern. There's no like consistency to it. It's just freaking the hell out. It's all over the place. Okay. Does that make that clear up a little bit? Those differences?
Thank you.
Yes.
Let's see
I'm
if we can
switching to
find-
my phone for a few. I will be back onto my laptop in a few minutes. I gotta walk the dog.
Okay. Let me see if I can find any others that are cool. This just looks like, again, we don't really talk about hyperkalemia. Doesn't look like they have a doesn't look like they have an example of what I was going to look for, like atrial AV block stuff. But I have some.
He asked a lot about those on the practical exam we had.
Yeah, that's a super common one that they like to ask about. Me.
I'm in the quiz, not the exam. Sorry, haven't had the exam yet.
Jeez Louise, come on, computer. Delete. Let me close a couple of things. See if I can have help my computer. Not freaking out. And we're frozen. Let's give it a sec. Want to close this. Okay. Save this. And close it. Okay, that will keep. Okay. This next one. This goes over. It should be included within notes stuff as well if you got my notes. This goes over every single one of the abnormalities and what to look at. No, where's the other one? This one? No. Might be my lecture stuff. Let me look. Let me see if I can find it. because I put together like each, here we go, here it is. In the exam 2 study guide, I go into all of this stuff. So for example, looking at EKGs, I tried to pull examples of every single one of the types of pathologies that we could have, like the causes of it. So tachycardia, remember we measure the big boxes and the small boxes, looking if it's between 60 and 100, we're good, which is between 3 big boxes and 5 big boxes. If it's between that range, we're good. Anything more or less than those numbers, that is our tachycardia or bradycardia. So there's sinus bradycardia. Our abnormal P waves show us the different hypertrophies. You really won't see these in EKGs that he'll give you examples of. The ones that he will hit a lot are the AV blocks. So biggest thing to remember about the AV block is that it has to do with the AV node. The AV node, remember, its purpose is to pause the signal that's coming from the atria. It pauses the signal to allow for everything to finish filling before it passes it along into the ventricle for everything to continue going. So when we look at the EKG, what we're going to be looking at specifically is the PR segment, or you could say the whole PR interval, where the P wave is in relation to the QRS complex. So we have different degrees of AV block, meaning that the signal is getting blocked too much at the AV node. A first degree just means that the PR interval is longer than 0.2 seconds. Okay, so if we count up the boxes, each of those boxes is 0.04 seconds. So 5 of the little boxes, it's more than 5 of the little boxes. We know, okay, and it's like that consistently. It's consistently long, like the same amount long every single time. That's our first degree AV block. Second degree, so part of this is, there's 2 components to these. The first part is just knowing what is meant by first degree, second degree, third degree AV block, and then how to actually identify it on the EKG. Okay, so first degree is just a longer PR interval with everything else being normal. Second degree, we have 2 different types. We have a type 1, also called Wenkenbach. So type 1 is a Wenkenbach, where the PR interval gets progressively longer until you get a dropped QRS complex. So here we go. We have our PR interval. We have a P wave, QRS, T wave, P, QRS, T wave, P, dropped, nothing there, P wave, QRS complex, T wave, and it slowly gets bigger and bigger and bigger. Type 2 of the second degree occurs with a large anterior myocardial infarction. The PR interval is fixed, and the P waves occur in regular ratio to QRS. So what that means is that the distance between the P wave and the QRS complex is not increasing, but we have a consistent dropping of QRS complexes. So for example, in this one, we have 1 QRS complex, 2 QRS complex dropped, 1 QRS complex, 2 QRS complex dropped. So in some kind of ratio where we'll see, 2 fully complete ones and then a dropped one. 2 complete ones and then a dropped one. Or we'll see 3 complete ones and then a dropped one. 3 complete ones and then a dropped one. This one isn't super commonly tested on. The ones that are more commonly tested on are the Wenkenbach or just the regular AV block. And with all of these conditions, with like the AV block ones, the easiest lead to look at is typically lead 2 when you're trying to identify these. 3rd degree, complete AV block. There is no order, no consistency between the P waves and the QRS complex. It's also known as ventricular escape rhythm, essentially meaning that the ventricles are just doing their own thing. We can kind of look at this and we can look and see, okay, P wave, P wave, P wave, P wave, P wave, P wave. There's no real order of when P waves are happening compared to QRS complexes. Because if we remember that before, where's the signal coming from before it gets to the AV node? What's setting our typical pace?
SA.
Our SA node. If our AV node is blocked, meaning that no signal can get through, right? How are our ventricles going to respond to that?
Wasn't it Purkinje fibers?
Yeah, we have either the AV node itself, like some part of the AV node itself is going to send a signal down, or the Purkinje fibers are going to set up a signal to be to go along. So either of those could occur depending on, the exact cause of the AV block. More condition, we have Stokes-Adams syndrome. It's a complete AV block that comes and goes randomly. This is essentially like kind of like your heart skips a beat, but it can, kind of, you're walking, you're doing your thing, doing whatever, and then all of a sudden your heart goes funky for a second. And this can happen once a month, once every 6 months, once a year, once a decade. Like there's not really a whole lot of, consistency to this. It's very, very random. 99% of the time when they ask questions about it, they ask about syncope. They say a patient comes in with sudden syncope, randomly occurring every couple of months. Lean towards Stokes-Adams syndrome is typically your answer.
Greg, is that also the one where, because there's one where where is that more like tachycardia and bradycardia, where it'll like speed up for a second and then slow back down and then speed up for a second and then slow back down? Is that the same thing? I know I've seen one somewhere in one of the lectures. I don't remember what lecture it was.
That's not ringing any bells right now. He might have added a condition.
I'll say he may have added it into the it may have been in the arrhythmia lecture, but I don't remember.
Like this one, paroxysmal tachycardias.
Potentially?
Might be this one. We'll get to those in a sec and we can see. An incomplete intraventricular block. This one doesn't really get tested on a whole lot. But basically you get these alternating in size. You get a big QRS complex and then a baby one, and then a big QRS and then a baby QRS and a big, alternating like that. Bundle branch blocks. biggest things to look for our the V leads. Look for our little bunny ears. If you see the bunny ears, that's how you know that you have bundle branch blocks. Along those same lines, make sure that you remember there's typically a handful of questions about the V leads, like which V lead corresponds to which part of the heart. I think I have that included in here somewhere. Maybe not.
Is there a good way to remember that?
The V leads?
Yes.
Is just straight. You just need to memorize it.
Okay.
I wish there was a better way, but it's literally you just need to remember which one correlates to which one. It's just one. It's one of those things. Like there are certain things it's literally just raw memorization, and I hate that kind of stuff. But unfortunately, certain things are just like that. Let me find. I know that I saw a V lead here somewhere. Not in there.
If I remember right, I think V1 and 2 is one of the ventricles. Isn't 3, 4 septum and apex or something like
So
that?
3, 4 is septum and apex. 1 and 2 are right atrium. 5 and 6 are left ventricle. No, sorry, right ventricle for 1 and 2. And then apex and septum for 3 and 4. 5 and 6 are left ventricle. It was in this week's lab, so it should be week 7 lab.
I saw it going through the other stuff though, which is why I had it written down in one of these. The reason why is because we'll see if Dr. Tate does this or not, but when I took because we had that same sort of breakdown where 3 and 4 is the septum and the apex, and then we would get test questions that were like, which of the following is the V lead for the apex? And it would have V3, V4 both as answer choices. Whereas we don't learn it as separate, we learn it as them together. So that's why I was trying to find, I had it written down. It's written down here somewhere amongst all of this stuff.
That's my favorite kind of questions when you either never seen it before or it's like, this is information we were not given.
Yeah, or it's like it's information that, is, and that was the big issue with the previous instructor, where I really liked her as a person. English was her third language. So a lot of times things got lost in translation. So like a lot of her test questions got lost in translation. So that was one of the reasons Phys was very, very difficult when I was in the class. But okay.
And when did she stop teaching? Like in Parker?
She stopped teaching 2 tries ago, I think.
Okay, just wondering.
I think, actually, counting this try, Dr. Tate took over full-time last trimester.
Oh, so he's super new. Okay.
Yeah, he taught blended last trimester and the try before that. And then he moved to in-person and blended last trimester.
Okay.
So, yeah. Okay. Premature atrial complex, PAC. These are extra beats. They originate in the atria. With this, essentially what you'll see is you'll just see like the QRS complexes are evenly spaced out, except randomly you'll have one that's just closer together than all of the rest of them. Again, not something that's super commonly tested because it's not super like obvious. So also word of advice with EKGs. When you do see them, most of the time with EKGs, like you're not looking for super nitpicky things. Like if they have an issue with them, the issue typically is pretty obvious. Like this one down here, like that massive thing, that premature ventricular contraction is pretty obviously different than what everything else looks like. If you're like super nitpicking, trying to like, oh, well, like this one PR interval looks like it's one small box too big compared to what it should be. Like you're reaching. Okay. So if it's going to be a pathology, it's going to be decently like obvious. It's not going to be like super nitpicky. Paroxysmal tachycardia. This is, I think, yeah, this is what you were talking about, Liz. It's a series of rapid heartbeats that suddenly start and suddenly stop. And you can have it originating in the atria, in the AV node, or in the ventricles. So we'll call it, if it's happening in the atria, we call it supraventricular. It's atrial paroxysmal tachycardia or supraventricular tachycardia are the two ways that you'll see it written. And the P wave is going to be inverted. So see here, as soon as it gets fast, we have our upside down P wave.
It's also called PSVT.
You said PSVT?
Paroxysmal supraventricular tachycardia. Paroxysmal supraventricular tachycardia.
Yeah.
Sorry, it's a mouthful.
Yeah, I didn't like all like the big word terms. So biggest things to look, the key for a lot of the EKGs is just recognizing like the specific keywords. So the supraventricular tachycardia, inverted P wave, and it suddenly gets faster than it's supposed to be. The ventricular paroxysmal tachycardia, we have no P waves. We have like a normal QRS complex, P wave, QRS, T wave, P wave, QRS, T wave, blah, 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 random, sporadic, faster than everything else, no P waves, and then it goes back to normal. This is the one that you're going to see different. I promise you there's going to be an atrial flutter and an atrial fibrillation, either on lab exam or lecture exam. You'll see it on at least one of them, if not both, okay? Atrial flutter, you'll always see it described as a sawtooth pattern, okay? Atrial flutter has a symmetrical shape, meaning that the P waves look like P waves consistently, like P wave, P wave, P wave. Like they're not crazy looking. It looks more like I said, like a sawtooth. Atrial fibrillation is different, where everything in between the QRS complex just looks like a toddler with a crayon on a wall. It's random. It's all over the place. It's bouncing all over the place. There's no clear kind of shape to it. Okay, that's how you tell the difference between flutter and fibrillation. If they're ever describing one, which they typically do ask a question of like which of the following is typically identified as a sawtooth pattern, that's flutter. Flutter is the sawtooth. Fibrillation, no clear P waves. Everything is just kind of in chaos. ventricular fibrillation, everything looks funky. This is your toddler running free with the crayon or with the Sharpie against the wall, just all over the place. It kind of reminds me of, like, you ever seen like how Spotify has done like those song things that you can take a picture of?
It's literally just what I was thinking about because we have one of those.
Yeah, that's what it looks like. Cool. It's just, like, it looks for chaos. Like I said, they're not trying to trick you with the EKGs. A lot of it is, just kind of taking a breath and not trying to read too much into it. Okay. And sometimes if you look at an EKG and it looks like there's nothing there, look at your answer choices. Chances are one of the answer choices is normal EKG. Half the time, if you guess normal EKG, you're probably correct as long as there's nothing blatantly wrong with it.
Did you already talk about with the EKGs and stuff, the different formulas?
I think we did.
Which formulas?
The end-diastolic and systolic.
No, I don't even know exactly. Everybody's talking about these formulas we need to know and need a calculator for tomorrow, and I'm like, what formulas? I don't know what you're talking about.
For EKGs?
Yeah, other than heartbeat, which you need to be able to divide by 300, but I'm pretty sure I can do that in my head. Like,
Is it the one that gets divided by 1/3 or 0.3?
maybe I don't know. Everybody's freaking out about these, so I'm not. Oh, maybe it's those that you just set up. Maybe that's what everybody's talking about.
It might be these. Monitor pressure, pulse pressure, stroke
Yeah,
volume.
I bet that's what everybody's talking about.
Probably.
Okay.
I was putting these over here, so I'll send these to you. Okay. Looking at treatability. Usually there's one question about treatability. Electrical shock to defibrillate the heart. Electrical shock is only for, like, the fibrillations, VFib or AFib. If you have a flat line, that means you're dead.
Shockable.
Cardiac arrest, non-shockable rhythm.
Also with atrial fibrillation, now they call it cardioversion. They still shock you, but
That's above my pay grade.
that's what happens when you're a paramedic.
Wandering atrial pacemaker. I think wandering atrial pacemaker got brought up maybe once the entire time I took the class. Just like the pacemaker site shifts between the SA node, the atria, and or the AV node. So just like P wave looks funky, and like the distance between stuff might change depending on where it's originating from. This isn't one that's like super diagnosable, unless I would just again look at P waves. The first thing that you do when you see an EKG, in my opinion, first look at the whole thing and look to see, like, does it roughly look normal, or is there something super crazy obvious that's like, that's weird, that's not right. And then from there, I usually start at the beginning. Look at the P wave. Is the P wave inverted? Is the P wave normal? Is the PR interval normal? Look at the QRS complex. Is the QRS complex too high? Is it too low? Is it too wide? Is it too wide? Then move on to the S. If everything's good there, look at the ST segment. Is the ST segment up or is it down at least one block? No? Cool. T wave. Is anything going on with the T wave? And typically by that point, like T wave, honestly, we don't really care about. So If you haven't seen anything and you've gotten to T-wave, more than likely it's probably normal. Ventricular tachycardia. This will be, I guarantee you, this is always a rhythm that they put on. You'll see a handful of those. Sometimes they'll have, I've had like one of my exams, I think I had 4 of this exact ventricular tachycardia. And I was like, what's this? What's this? What's this? And I like had to pick ventricular tachycardia every single time, and it just freaked me out. Because I'm like, this is not supposed to be the same thing every single time. But yeah. Okay. Is there any other chunks, I guess, like, for your guys' lecture exam, Liz, have you guys gotten any further than EKGs?
No, I don't think so, because the last thing we went over was the arrhythmias last week. I mean, this week won't be on there because he can't even lecture this week yet because of our test. So,
did you guys already
think
talk
so.
about like the mitral stenosis, regurgitation, heart sounds, all of that stuff?
We
He
have.
did touch on them. I don't think he went super in depth, but he did touch on them.
Same for us.
Okay. So heart sound, did he give you guys like anything like this? That's like, is it systolic, diastolic? What does it sound like? Where do you listen to it? All that?
I believe
Not
not like that, but he mentioned it.
He mentioned it. I don't remember seeing anything in the notes. I'd have to look back through my notes from last week.
Okay. I don't like that because, so like for our exam too, we got all the way through like all of like the vasculature stuff. Like all of this was exam 2.
Just started vasculature this week, which won't be on the test.
Okay.
And then
you guys haven't done vasculature, Liz, have you?
No, we have not. And then like in lab today, I think we did. It had more to do with the axis and stuff again, which he pissed me off. I'm not gonna lie, but because I was like, okay, can I do it this way? Because this is the way that makes sense in my brain. The like shading, and he was like, well, you can't figure out the axis that way. You can only figure out the deviation. And I was like, you lied, but okay.
No, you can figure out both.
That's why I just looked at him. I had a little bit of attitude with him because he said that and I went, then I don't get it.
The deviation is still the axis.
Yeah, so that's why he kind of made me mad, because I was like, you have to have the axis to figure out the deviation, sir.
Well, no, because you solve for the axis.
Yeah.
And then
you can tell what the deviation is based on that. You look at
the axis and see if it's deviated or not.
Yeah.
Okay, yeah.
He made me mad, and then he kept talking and confused me more, and so I was ready to walk out of lab today. It was bad.
Don't worry, Liz. You just do the shading. You know how to do it.
I was like, that makes sense to me. Why do you want me to do it some other way?
Because his way is the only way, apparently.
Just do it the way you want it. That'll make sense, okay?
Mm-hmm.
Heart sound, what I would probably guess is he's probably gonna have, just like we talked about, like the cardiac cycle, that little rectangular, rounded at the top looking graph. Boom, this guy right here. He'll probably have like the locations of the heart sounds that you want to know. It's like S1, S2, S3, S4 on that, and kind of what they're about, lub dub, what's closing, what's opening, when and where and why.
Can we go over that one more time, Drake? Because I'm not sure on that one still.
And I feel like that's as deep as he went on it. Just like that stuff.
Because I feel I understand the pulse pressure thingy diagrammy, but I can't put the different things in accordance with it because my brain doesn't work that way.
Okay. So starting on this side, we have pressure. Down here we have volume. We draw our little doohickey. Oop. I want it to look pretty. Woo-doo-doo. Wabba-da-ba-da. Wee.
Thanks, Drake.
Oh, that last line isn't pretty. That sucks. That's fine. Change colors. Oh, red. Orange, I guess, fine. A. B. C. D. E. F. G. H. I. That's probably enough letters, right?
That's an alphabet soup if I ever saw one.
Yeah. Okie dokie. Let's start at A. Okay? So A, right here, at this very particular spot, as we start from going A to B, let me actually do this. I'm going to take this pretty thing.
Put it in whiteboard.
I'm going to put it into words so that I can type because I don't have a nice... I have them on my desktop computer. Okie dokie. So let's write out A to B. What is happening from A to B?
Atrial.
Let's look at the graph, right? Let's look at the graph. So our volume here, let's say this is 50 and this is 100. Is the volume increasing or decreasing?
Increasing.
Yeah, and let's also do this. And this is the cardiac cycle, aka whatever the hell the ventricles are doing. Okay. So from A to B, we have ventricular filling. There's two components to this, right? We have H and we have I. H is the passive ventricular filling. That means the atria are not contracting. Gravity is doing the work. I, we have active ventricular filling. Atria are contracting, putting in that work. Okay. The passive accounts for 75% of filling. Active accounts for the final 25% of filling. And we'll come back to these in a second. Point B. What is happening at point B? So after we finish filling up the ventricles, right, from the atria into the ventricles, what happens as soon as we're finished filling?
They get ejected. Or back pressure builds and then it gets ejected.
So
Eventually.
the AV node or the AV valve has to open so that it can be ejected.
Let's pause.
Nope,
Let's back up
semi-lunar
a second.
valve.
Semi-lunar valves eventually will. But right now we're talking about just right here, okay? We're just going to zoom in. We're just talking about this part right here. We're ignoring everything that's happening up here. Point B. So from A to B, we're filling up the ventricle, right? So we have our heart. Boop. Boop, boop. So right, here's our... Let me draw. Come on. Here's our heart, right? It's split into four chambers. And then we have valves that open from the atria to the ventricles, right? The blood flows through the atria into the ventricles to fill. So in ventricular filling, blood passes from the atria into the ventricle through the AV valves, tricuspid and mitral valves. During the first 75%, it does it passively. During the last 25%, it does it actively. At point B, it's done filling. So as soon as we're done filling, we got to put the lid back on. So the AV valves,
Close.
the tricuspid and mitral valves close. When valves close, are they silent or do they make a sound?
That's when they make a sound.
They make a sound. Of all of the sounds, the way that we number them, 1 through 4, which sound is made with the AV valves closing? 1, 2, 3, or 4?
First.
S1. So this is the first step. This is the first sound that's being made. So S1 heart sound is heard here, and that is our lub. Some teachers say lub, other people, apparently parts of the science world are really divided about the whole lub-dub thing, which I think is hilarious. Okay. So now traveling B to C. We'll put a little F in parentheses. From B to C, so we've filled up the ventricle. Now that the ventricle is all full of blood and the AV valves have closed, what does the ventricle start to do?
Contract.
Yeah. So the ventricle begins to contract. What's going to happen to pressure as the ventricle contracts?
It's going to decrease.
It's gonna
Think about
increase.
Pressure will increase, volume decreases.
Let's think about it first, though, right? Because where's the blood supposed to go as the ventricle starts to squeeze?
Either pulmonary or up through the semilunar valves.
So eventually, that's its goal. That's where it wants to go, right? But if we pause and we think about this, our blood, we already have our whole vascular system is a closed loop, right? So on the other side, so let's say right here, here's our ventricle, this little box, and then it goes out into our aorta, right? And there's a lid right here. And this lid can open out this way, right? But if we think about it, we have a whole bunch of blood putting pressure on this other side of the door. So this is all full. And this is all full. But the pressure out here in the aorta, right, when the ventricle is squeezing, what's the pressure that's going to be in this aorta? What do we call that pressure?
Shoot.
We call it our systolic blood pressure, right?
Yeah.
So the systolic, when we talk about quote unquote normal, what's our normal systolic blood pressure?
120.
120 millimeters of mercury. So there's 120 millimeters of mercury pushing, keeping the door closed, preventing that door from opening. So we could say, we can change it, think of it like there's a fat man sitting on the side, on the other side of the door, and we're trying to open and walk through that door. The only way we're gonna get through that door is if we can push hard enough to overcome that fat man sitting on the other side of the door. That's the situation that we're dealing with right here. So the ventricle begins to contract, increasing pressure, but volume is staying the same because the semilunar valves are still closed. Okay? Pressure continues to build. This is called isovolumetric contraction. So isovolumetric contraction, this F, B to C, this F point right here, is the ventricle is contracting, pressure is increasing, volume is staying the same. So our pressure builds, the amount of push that we're pushing against that door is building and building and building and building until finally at C, the pressure in the ventricle surpasses the pressure in the vessels, and the semilunar valves open. Does that make sense? The order of that happening? Does that make sense?
Yeah.
Liz, does that make sense?
Yeah.
Okay. I need to know. I need to be confirmed from everybody. So as soon as the semilunar valves open at C, from C to D, also known as G, now our blood is leaving. This is ejection. The blood is leaving the ventricle and going into the aorta / pulmonary arteries. So we push the blood out, 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 until we decrease the amount of volume of blood, right? And if we think way back, I think it's either in physics or chemistry that we learned this. PV, P1V1 equals P2V2. Or something along those lines. Do you guys remember that?
I remember hearing
something like that.
I don't remember it at all.
Okay, that's okay. What that rule is saying is when we change the volume or the amount of stuff inside of something, we also change the pressure. Okay, so if we change the amount of volume that's in there, we change the amount of pressure. So in this case, we're emptying. So ejection, the blood is leaving the ventricle, going into the aorta, the pulmonary arteries. The ventricle is emptying, which means the pressure is going to go down. When the pressure goes down and we reach the point D, right? Because in our aorta, we're sitting at like that 120, that 120 whatever fat person is leaning against the door. As soon as we decrease the pressure below that, what's going to happen with those valves?
Open so they can fill again.
The semilunar valves. With the semilunar valves snap shut or close. And when things close, they make a noise. So there's our S2 heart sound is heard. And that's our dub. Then from D to A, also labeled as E, we have the ventricle now is going to be relaxing because it contracted all the way up. It's got the blood all the way out. It did its job. So now it's going to take a breath, take a sinus, and relax. That is isovolumetric relaxation. So the ventricle is relaxing and going back to its starting position. And finally, we get back to A. As soon as the ventricle is relaxed, the mitral and tricuspid, those AV valves, open to begin filling once again. So starting at point A, mitral and tricuspid valves are open. We get active filling of the ventricles. It turns into, we get passive filling of the ventricles. That turns into active filling of the ventricles. The AV valves close and we get our S1 heart sound. The ventricle starts to contract and we get isovolumetric contraction. Pressure builds until the semilunar valves can pop open. As soon as the semilunar valves pop open, we get an ejection of the blood. And as soon as we finish ejecting, we push all the blood out. There's not enough blood to keep pushing out. Those semilunar valves snap shut. And then we get isovolumetric relaxation. The ventricle is relaxing, going back to its resting state. As soon as that ventricle is relaxed, our AV valves snap open, or pop open to allow for passive filling. And then they actively fill. And then those AV valves snap shut. And then it repeats over and over and over and over again.
And then I know he's used that graph before too for like where is ventricular depolarization happening and where is repolarization happening.
Okay, let's add that in. So first thing we'll add a line right here. This is systole and this is diastole, right? So if we think about it, ventricular depolarization. What happens after you depolarize a muscle? When a muscle cell gets depolarized. Yeah, so when the muscle cell gets depolarized, that's when it's pretty soon afterwards, it's going to start to contract. So if we look at this, depolarization of the ventricle, somewhere in here, let me use a different color. I would put it, here's where it depends on the teacher, because let me step on my soapbox real quick. And I mentioned this earlier. Technically, depolarization and contraction are two completely separate events, and you cannot tell when one of them happened by looking at when the other happened. You're not able to do that. They're two completely separate things. Some professors don't buy that, and so they look at it like this. If the ventricle is contracting, then that's when depolarization is occurring. So technically, you can look at this whole thing and say, because this is technically correct, during this entire chunk of material, I would argue somewhere between point B and point C to be like the most specific. Somewhere between B and C is when you get ventricular depolarization is occurring.
I feel like that's what he has said is like between those two.
Yeah. Technically, it would be like right before B, like milliseconds before B. So best answer of what teacher wants is probably going to, if you, depending on what answers he has, my first answer choice, quote unquote, the best answer choice is going to be at point B. So we'll do this. So best choice equals at B. Next best equals between B and C. Other choice during systole. That's kind of the order at which I would rank, what answer, depending on what answer choices are available to me. Other side of that, then we look at, okay, getting bit by a mosquito in my house. What the heck? Ventricular repolarization is occurring during relaxation. So best choice at D. Next best choice between the D and the A during diastole. That is how bring that front. Oh, shoot. That is the way that I would answer that question. I don't love that question personally, but whatever the teacher wants to do is on them. Does that make sense?
Yeah, that makes a whole lot more sense than how he tried to explain it.
Okay. Let's add in there as well atrial depolarization, right? So if we think about it in general, depolarization equals contraction is kind of what he's getting at. So atrial depolarization occurs when? So we look at our whole thing, filling. Atria are open here. This is all passive filling. We don't get active filling until I. So atrial depolarization occurs when? Best answer, I would put, depending on what he has there, I would put when active filling begins. If that's not an answer choice, then I would pick point A or between A and B as my answer. That's what I would pick. Because during active filling, technically when active filling begins or just before active filling, depending on how he words it, and then atrial repolarization occurs when, as soon as we get atrial relaxation. So anytime after that, really, atrial repolarization occurs after active filling is completed. So could be point B. Because if we think about it, when we look at our QRS, or our EKG, we have our P wave. What does the P wave represent?
Ventricular dipolar, or the time between ventricular and atrial. I can't remember.
P wave, right there. P wave equals atrial depolarization.
Oh, PR interval is the time between the two. That's
Yeah, PR interval is PR interval is the AV node delay. So why don't we see? And then we keep looking at it, and our R wave, and our T wave, our R wave. Jeez, come on, word, freaking word. Represents ventricular depolarization. The T wave represents ventricular repolarization. Where's atrial repolarization?
You can't see it in the EKG because it happens like it's basically inside the QRS complex.
Exactly, it's getting swallowed by the QRS complex. So if we ask about atrial repolarization, when does that occur? During ventricular depolarization. So whatever our answer choices here are for ventricular depolarization, at B, between B and C, during systole, any of those answer choices? Perfect, that fits for atrial repolarization. So any of answer choices for when ventricular depolarization is happening. Does that make sense why?
Mostly.
Okay. Because our atrial repolarization is getting swallowed up by the QRS complex, that means the repolarization of the atria and the depolarization of the ventricle are happening simultaneously.
Okay.
So because they're happening simultaneously, if I were to ask the question, hey, when does atrial repolarization occur? A perfectly acceptable answer is, oh, atrial repolarization happens at the same time as ventricular depolarization. And we said just previously, ventricular depolarization happens at some point and completely during all of this stuff happening here. So cool beans. Couple things I'd say to hit before exam tomorrow. Review this several times, draw it several times, write all this out, write all this in there. And then the EKG. So EKG, you really want to have the EKG down of what is going on with EKG. So let's actually do this real quick. I'm going to give you the rundown of what to know for EKG. P wave, done, 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 done. Okay. P wave equals atrial depolarization. QRS wave equals ventricular depolarization. T wave equals ventricular repolarization. PR interval equals P wave to QRS. So we want to know, PR interval. We need to know the timing of PR interval. That is 0.12 seconds to 0.2 seconds. You have to know this time. You absolutely have to know that's the amount of time. The QRS wave, actually QRS complex, and that is going to be 0.06 to 0.08 seconds. You have to know this time. ST segment. ST segment represents can represent certain pathologies. We want to know ischemia equals depressed ST segment. It has dropped more than one small square from the isoelectric line, aka J point. MI, myocardial infarction, equals elevated ST segment, raised more than one small square from the isoelectric line, aka the J point. Also, you should know QRS complex. 1.5 to 1.8 in height. That is, let me double check. It's general rule of thumb. I think most people do the general rule is less than 20 millimeters. So each box is 1 millimeter, each small box. Every teacher does measurements slightly different. Like less than 20 is like standard, but I think most do 15 to 18 millimeters in height. If it is more than this, typically we'll see them at like 25 plus. That indicates hypertrophy of the heart. These are the big things with EKG. I think that's all of like the big, super like general things that you need to know with EKG. Is there any that you can think of that I'm missing? Okay.
Not that I can think of. I was trying to think if there's anything else he hit hard like in lab today, but I think that's pretty much it.
It's going to be a lot of questions of this kind of stuff. A handful of looking at EKG stuff, just understanding, you know, like the general flow of things. These are those equations. Let me save this. You guys did not have a lot of turnaround for exam 1 to exam 2. Holy cow.
Yeah, not at all.
It was what, like 2 weeks, 3 weeks? 2 weeks?
2 weeks. I'm pretty sure it was like 2, maybe 3.
Yeah, we had week 4, 5, 6, and week 8 is our lecture exam.
Yeah, so we had 3 weeks for ours since it's this week.
Yeah, that's weird how you guys are a week off.
Okay, I just sent that in the chat. Those should be the big main ideas of what's going on.
Yeah, I agree. I'm just looking forward to getting lecture exam or lab exam over so I can take and turn around and do lecture next week.
It's a lot. It really kicks your butt.
Yeah, next week I have 3 lab practicals on Monday and 2 exams on Tuesday.
That seems like a lot. I don't know why. I feel like, how many exams did we have in? Let me look real quick. Try 2. Here's 1. Yeah, so we didn't take our second exam until after week 8. So week 9, and then I do remember like our exam 3 and then our final. Like I think our exam 3 was like week 13, and then our final was week 15. And we had, that's why appropriate lecture material from hell is because we had all of this material in like 2 weeks.
Jesus.
Yeah, and his is going to be cumulative, which also sucks.
The final?
Yep.
Yep. Either that or we can
Yeah.
praise like Dr. J and he has mercy on us and just goes over the last 2 units.
Yeah, but no one's like Dr. J, so.
We love Dr. J. Can we have him for more classes, please?
Someone wrote, "You are awesome."